Thank you very much for your kind invitation and to the organizers for organizing this exciting session. I think it's going to be a very interesting day for everybody involved, and very exciting to see this topic taking such preeminence in your conference. I'd like to introduce myself as the Division Chief of Cardiology here in Los Angeles at Children's Hospital, and my topic today will be to discuss medical therapies in pediatric heart failure. I'm hoping you can see my first slide and can hear me clearly. I will disclose that I do have a consultant role with Novartis and Merck and Bristol Myers Squibb. I will discuss the use of medical therapies which are not yet labeled indications by the FDA, anticipating that this will happen soon. I will also discuss the early results from the Panorama study, which was a study of sacubitril valsartan in children. So what's new in 2022 for heart failure medications? There are a few things that relate to heart failure as well as to the medical therapies, and I will talk about the classification of heart failure, the management approach to stable congestive heart failure primarily in this talk, and the introduction of medical therapies, the use of angiotensin receptor neprilysin inhibitors. Year after, I will refer to this as an ARNI, and this is the only drug in its class that's currently marketed under the trade name Entresto. I will briefly refer to avabradine, to the SGLT2 inhibitors, an exciting new class of drugs that has been introduced for adult heart failure therapy. And then I'll talk about some other drugs with evidence of benefit in adults which are not yet evidence-based in children. So where do we come from at this point with new guidelines in heart failure established by the American Heart Association and the American College of Cardiology in 2022? We're going to cast our eyes to step 1, step 2, and step 3 on your screen. And we're going to focus on these as the established goals for establishing heart failure therapy, where we use 4 drugs now, as well as diuretics as class 1 indications, and we try to introduce these all very quickly in patients who have LV ejection fraction of less than 40% and are classified as stage C heart failure. The next step is to titrate all of these to target dosing as tolerated, but as a key point, we do not require one to reach a target of one drug before introducing the next. This is a completely different approach to what was used before. And so it's important for us to realize that it's established now that the standard of care is to introduce all of these drugs as soon as possible after graduating a patient from vasoactive therapies. And then to consider specific scenarios, particularly patients who have African-American heritage, because these patients have a class 1 indication for hydralazine nitrate therapy. Specifically, patients who have a low ejection fraction because of their potential need for an ICD, and in certain cases, patients who would benefit from cardiac resynchronization therapies. So how do we stage heart failure, and what do I mean by stage A, B, C, and D? These may be well known to those of you who practice in this area, but for those of you who are not that familiar, let's recap that stage A means you're at risk for heart failure. You may have an underlying disease process as indicated here, perhaps an exposure to a cardiotoxic drug or a genetic variant of cardiomyopathy or family history. You're at risk, but do not yet have any changes in your heart. Stage B, I would say B for before, just before heart failure starts, you will have some structural abnormalities evidenced by increased filling pressures or changes in the ventricular shape or ejection fraction, but importantly, no symptoms yet. In this stage, we now consider patients who have increased biomarker levels as being in stage B, pre-heart failure. And then stage C, these are the patients with symptoms. These patients can have symptoms that either remit with medical therapy or progress despite medical therapy, but they will always remain stage C once they have had symptomatic heart failure. And then finally, stage D, these are the patients who are markedly symptomatic and have unremitting heart failure symptoms for whom there are fewer medical therapy options. And so to look at this from the point of view of therapy, we can say that for stage A, at this stage, there's still no clear evidence base for heart failure therapy when all you have is an at-risk status. For stage B, there is emerging evidence for efficacy for both ACE inhibitors and mineralocorticoid antagonists. Think about Duchenne muscular dystrophy as a good case study for this. Then most of the focus for stage C heart failure is that there is very good evidence for medical therapies to prevent progression of disease. And for stage D, not so much. These patients typically rely on vasoactive support drugs as a bridge to advanced therapies that we will hear more about this morning. Let's take a closer look at heart failure stage C now. These are the patients who have had structural changes and continue and have presented with symptomatic heart failure. This may be their first presentation, as seen on the left, with no prior history. They may in fact have resolution of symptoms, but patients who have stage C heart failure with resolved symptoms still require medical therapy. And that's the main message here. Patients whose symptoms and signs of heart failure resolve still require continuation of medical treatment in order to have the best outcomes. Some of these patients will have persistent heart failure with ongoing symptoms and a decrease in functional capacity, and eventually some of them will worsen and require advanced therapies, as we've said. So this is the overall spectrum of presentations and outcomes that occur with stage C heart failure, on which most of our activity is focused. Now, if you think this is a bit confusing, I'm afraid it gets a bit worse, because now we try to classify heart failure not only based on symptoms and structural disease, but also the type of heart failure as indicated by their ejection fraction. So patients with a reduced ejection fraction are known as HFrEF, EF less than 40%. Patients who start off with an EF of less than 40 but improve become patients with heart failure with improved ejection fraction. Previously, EF less than 40, now more than 40. Patients who maintain that status are patients who have mildly reduced ejection fraction in the 41 to 49% range. And of course, patients who have never had a reduced ejection fraction may still have heart failure with an EF of greater than 50%. We call this heart failure with preserved ejection fraction. The relevance of this is that these patients don't always stay in the same classification. So HFrEF can become heart failure with improved ejection fraction, and these patients, as I said before, continue heart failure therapies. Patients with mildly reduced ejection fraction can in fact deteriorate and will require an increase in therapy. We're not too sure about what happens with those who stay in this mildly reduced range, and so there's going to be more work needed for that. And then even more uncertain is patients who immediately improve from a mildly reduced ejection fraction to a normal range EF. How long do you treat them for? What drugs do you use? Do you still aim for all 4 therapies? It's quite uncertain at this stage. I will not be discussing very much more about HFpEF in today's talk. And so to make this a little bit easier, I drew this diagram to give you the 3 axial ways in which we classify heart failure. On the x-axis, we have this longitudinal time-related, usually trajectory of AHA class A, B to C to D, which relates to how severe their disease is over time and to the structural changes and symptoms. And then on the y-axis, we have the ejection fraction, which gives us a specific phenotype of heart failure, which is independent to some degree of the symptoms. And then on the z-plane, we can also classify patients according to their symptoms at that specific point in time, which helps us understand how aggressive to be with medical therapy. And so, does this relate to medical therapy? Yes, it appears to. Patients with an EF-specific phenotype, HFrEF, have multiple options for medical therapies. Those with HFpEF, not so much. Patients with symptoms, absolutely. They all need medical therapy, starting with decongestive therapies and diuretics. And then patients in the A, B, C, D classification, we focus mostly on stages B and C because these are the ones that benefit the most from oral medical maintenance therapy for heart failure. And there are 3 important drugs that I want to talk about today that have now become the mainstay. Although beta blockers are still important, I will not be discussing them today since their therapy is well established. First of all, we'll talk about LCZ696, which became the first-in-class neprilysin inhibitor, angiotensin receptor blocker, marketed as the trade name Entresto. We'll also talk about avabradine, a funny current inhibitor that regulates heart rate, and then finally talk about the SGLT2 inhibitors, which have now assumed a very, very important role in heart failure therapies. The ARNI drug is the first-in-class drug. It became evident from a multi-center randomized trial in adults in 2011 that this had a major effect in improving medical outcomes for heart failure patients. And so with that, a Panorama study, the ARNI sacubitril valsartan ARNI pediatric trial, Panorama, was designed and took off in 2013, 2014, and is finally reporting now in 2021 and 2022. And this was a two-part study that first of all was dose finding and divided patients into three groups, aged 6 to 18, 1 to 6, and 1 month to 1 year. 180 patients were to be randomized in a head-to-head study comparing sacubitril valsartan with enalapril. And 105 sites in 30 countries participated in this landmark study. Completed enrollment in January 2021, and let's look at some of the inclusion and exclusion criteria for the study. First of all, this required patients to have heart failure symptoms, NYHA class 2 to 4 with biventricular physiology, so no single ventricle patients here, but they could have congenital heart disease, and they're required to have systolic dysfunction with an EF of less than 45% or fractional shortening of less than 22.5. This excluded patients who were hospitalized and listed for heart transplant, and that was quite important. These were very sick patients, typically at risk for being on inotropic therapy or requiring a VAD, and they were not enrolled in the study. We also excluded patients who had symptomatic arrhythmias, and also a number of other entities indicated here, which were not included in the study. These were the classes of patients that were enrolled, and around 360 patients were eventually enrolled, and these patients had a range of different anomalies, including congenital heart malformations, familial genetic abnormalities, idiopathic cardiomyopathy, myocarditis, acquired disease due to chemotherapy, and so on. And you can see that most of the patients recruited were in age group 1, 220, in age group 6 to 18 years, quite a number in age 1 to 6, and very few in group 3, age 1 month to 1 year, for which reason the 1 month to 1 year group was broadened to change to 1 month to 2 years during the assessment of the data. And so what we saw in these three age groups revised, we had 70 patients in this revised younger age group, 85 in the medium child age group, and 225 over age 6 years. Assessment was over 12 months, comparing enalapril to sacubitril valsartan, and a global rank endpoint was established with 5 categories, of which 1 was the most severe, and 5 indicated improvement. And so there was 1, 2, 3, 4, and 5. Any of those could occur. In category 2, there were 3 subgroups, which we'll look at for a moment. 1, 2, and 3 all indicated worsening, 4 indicated unchanged status, and 5 indicated improvement. And so here is some of the endpoint data as presented at the ESC in August, and will soon be put forward for publication. And so this is informal data that I'm reporting, and it is not sanctioned by the sponsor of the trial, but simply to tell you that 187 patients were randomized to sacubitril valsartan, 188 to enalapril, for a total of 375. And you can see the outcomes here. The total outcomes, 49 deaths on the right-hand side, 162 improved, and the rest in between. A number of which were worsening, some requiring hospitalization, some worsened without hospitalization, and some staying about the same. 102 patients stayed unchanged overall. And comparing sacubitril valsartan in purple to enalapril, in fact, there were very, very subtle differences without much significance. And so what we can see was, although there were numerical favorable improvements for the numbers of those that patients were unchanged and improved, there were relatively few deaths in both groups, but less so in the sacubitril valsartan than the enalapril group. Putting this through to statistical analysis and telling wins versus losses, so wins in the sacubitril valsartan group versus wins in the enalapril group versus the equal percentage, There was a tendency to improve a little bit more with sacubitril valsartan than there was with enalapril across all 3 age groups. However, the odds ratios were very modest and none of these reached statistical significance. In terms of quality of life scores, we did see improvements in the pediatric quality of life inventory for sacubitril valsartan versus enalapril. And the global impression of change score was also better for sacubitril valsartan than it was for enalapril. So at this stage, how and when to use this drug? Strangely, it does already have an FDA indication based on the improvements in BNP data for patients over 12 months of age. And so, in fact, it is a labeled indication for heart failure in children for over 12 months of age at this stage based on that response. And we consider it safe to commence in patients immediately when transitioning off inotropic support in hospital, although you cannot use this within 36 hours of being exposed to an ACE inhibitor. A washout is required. It seems appropriate now to replace existing ACE inhibitor therapy if that's feasible. It may have a more pronounced drop in blood pressure when starting this drug than with an ACE inhibitor. And uptitration is in 2 steps for most patients, usually over 2 to 4 weeks to the recommended target dose. Generally, we are replacing ACE inhibitors with this medication in all of our patients with very few concerns, and final efficacy data is still awaited. I'll move on to talk about ivabradine. This is a funny current inhibitor which targets phase 4 of repolarization, and therefore in the sinus node enables the ability for repolarization to be slowed and a slower sinus heart rate to occur. This was the subject of a multi-center randomized controlled trial, placebo-controlled trial, conducted in 47 centers across 16 countries, which was published in 2017. This was a phase 2 study, in fact, and intended mostly for dose finding, with some emphasis on efficacy, but not powered for efficacy per se. And so patients required to have a history of 2 to 4 symptomatic heart failure with an EF of less than 45%. Only patients with dilated cardiomyopathy were enrolled, and these patients had to be on stable medical therapy to be considered eligible. This was intended, as I said, as a dose-finding study. We were attempting to reach an up-titration target to get a 20% reduction in heart rate without inducing bradycardia or symptoms, and treatment went on for 12 months. As you can see here, 122 patients were assessed, 116 randomized, and these were randomized in different age groups, 17 in the 6 to 12 month age range, 36 at 1 to 3 years, and 63 at age 3 to 18. And the randomization numbers to placebo are indicated here. A number of patients were withdrawn in both age groups, most of which were either protocol deviations or perceived adverse events, but none of these were serious adverse events, and none of these patients were hospitalized or required any additional therapy for that. Eventually, 74 patients were randomized to ivabradine at a 2-to-1 ratio with placebo in 42. These are the ages, and the heartbeat rate at randomization was around 100 for all patients. The EF was 32% in the ivabradine group and 35% in the placebo group, with NT-proBNP levels indicated over here with a range as noted. The causes were a range of different causes for cardiomyopathy, most of which were idiopathic, but some post-viral myocarditis and LV non-compaction as well. These patients tended to be fairly well treated on ACE inhibitors, diuretics, and on beta blockers already. Please note that quite a few were on digoxin as well. And then what happened? Well, heart rate came down predictably at the end of the titration period within a month and stayed low through the duration of the trial. Safety was quite well established, and patients who showed an improvement in their NYHA class was not significantly different between the 2 groups, but there was a numerical apparent favor for ivabradine to have a slightly higher improvement in ejection fraction, as well as New York Heart Association classes seen as in the bar graphs and in the plot over here from baseline through to 12 months. So not significant, but an improvement in EF in both groups. So how and when to use this drug? Well, tend to be using this in children over 6 months who are off inotropic support, and who persistently have tachycardia greater than the desired range. If a beta blocker cannot be tolerated or is ineffective, it's an alternative. And it's also being used in tachycardiomyopathy in patients with uncontrolled sinus tachycardia or ectopic atrial tachycardia. Next, I'd like to indicate that this should be considered before digoxin for rate control, as it has almost no toxicity and no off-target effects. Let's talk about the SGLT2 inhibitors, which have become the most important drug in adult heart failure nowadays. These drugs were found to be effective by serendipity when being used for mortality trials in diabetes patients, and found to have a major effect on heart failure hospitalizations. The SGLT2 receptors in the proximal convoluted tubule and is responsible for the reabsorption of most filtered glucose as well as excretion of sodium. And so when it's inhibited, it results in glycosuria and natriuresis. It does not interfere with endogenous insulin pathways. A recent number of trials, the dapagliflozin, DAPA-HF trial and Emperor reduced study, have both demonstrated efficacy for adults with heart failure, reducing their hospitalizations by approximately 25%. And here's some of the forest plots of a meta-analysis of both of the studies. All you have to see is that the risk ratio favors the use of this medication in virtually every adult with heart failure, virtually every age, any EF class, and virtually any comorbidity. And so it really has a broad-based positive effect in reducing hospitalization and all-cause cardiovascular death in heart failure. 13 to 14% for mortality, 25% for hospitalization, as I said, regardless of any of the other risk factors. What we don't know really is how they actually work. And what we think is that this is related to improved myocardial energetics, could also be to inhibiting the sodium hydrogen exchanger, which reduces mitochondrial death in patients with heart failure. But also perhaps other mechanisms that induce healthy autophagy of damaged organelles, as well as altering the fat levels around the heart, epicardial fat being an important risk factor for adult heart failure death. In children, there's almost no evidence for their use. There's one published paper that shows safety, but no attempt to really demonstrate efficacy. But nonetheless, I think it's fair to say that the indications for children, although uncertain, are starting to become eroded by the fact that we do not expect a clinical trial of this drug in children. And so use is now becoming widespread, typically in older children and adolescents, and those who have persistently reduced ejection fraction already on at least 3 drugs. It's also being used in patients who are obese with impaired glucose tolerance and mildly reduced ejection fraction. Next to last, omecamtiv mecarbil, an important drug that you should be aware of, is going to be coming up for FDA labeled indication in 2023. This is the first of the tropic drugs that will be affecting the contractile apparatus of the heart, and specifically the myosin, so the myotropic drugs. This will be the first of them that actually places the myosin heavy chain in the ready position for power stroke to occur and increases contractility. And in a large trial called Galactic-HF in adults with chronic heart failure and reduced EF, there was a composite reduction in the first heart failure event, hospitalization or urgent visits for heart failure or death, with a small reduction in relative risk of 2% and a hazard ratio of 0.9, but nonetheless an important addition to the armamentarium by increasing contractile function. So it's likely that this will become approved in adults. We have no data whatsoever for children. And then finally, vericiguat, another new drug approved in adults already that enhances the function of soluble guanylate cyclase and increases cyclic GMP levels both in the endothelium and in the myocardium, and is thought to improve vascular function in heart failure and thereby improve mortality in adults, as seen in this Kaplan-Meier curve. We don't have any adult pediatric data for this drug either at this point. So coming back to our original strategy, first thing to notice is that there's a class 1 indication now for 4 drugs, and we try to introduce all of those as I've mentioned. We start off with the 4 core drugs as soon as possible. We are happy to achieve a submaximal dose of several agents preferring that over reaching one drug at maximal dose. And so our sequence is to use an ARNI and an MRA, and then a beta blocker and an SGLT2 inhibitor if possible, and if it's deemed to be appropriate. We do not use SGLT2 inhibitors in very young children, but are starting to use them in older children and adolescents. We introduce one drug to reach one drug to target, a next drug to target, but not necessarily the maximum dose, but the maximum tolerated dose, and then introducing the next one in rapid sequence. A couple of words about heart failure with mildly reduced ejection fraction. We're not totally sure about how many drugs are needed in this class of patients and for how long they're needed, but most of us will use an ARNI and an MRA and think about an SGLT2 inhibitor. What about HFpEF? Again, there's a lot of uncertainty here, but the only drug that so far appears to have an indication of a positive benefit is a SGLT2 inhibitor in adults, and that even that is linked to the degree of reduced ejection fraction, or more evident in patients with a slightly lower EF than those with an EF of over 60%. So these other drugs may be considered to reduce hospitalization, but there really is no clear benefit for mortality so far. These are the drugs that I've mentioned today that have some evidence. I would just say that the ones that I've listed at the lower part of the slide here really have very little evidence and probably should not be used at this stage in children. So finally, I'd like to thank you and for your time. I think I'm just on time. I hope I didn't go over by too much, and hope that you can take some of this information and use it in your practice as you adapt to the new environment that we find ourselves in pediatric heart failure. Thank you very much.